Assalamu alaikum. Good day to all of you, dear doctors. Today, I'd like to share a brief discussion on about the topics of acute respiratory distress syndrome. In the last session, we have already discussed about the topics of burn, here's acute respiratory distress syndrome, all questions given. It is known to all of you that the acute respiratory distress syndrome is an acute diffuse inflammatory form of lung injury which is characterized by hypoxemia and decreased lung compliance and diffuse pulmonary infiltrations on the X-ray, and which is also characterized by normal pulmonary artery waist pressure which is less than 18 and ventilation perfusion ratio mismatch, and the partial pressure of arterial oxygen and fraction of inspired oxygen ratio is also decreased here, which is less than 26.6. Now, next question is how to differentiate between acute respiratory distress from the pulmonary edema. In case of acute respiratory distress, it is already known from the definition that here's the pulmonary arterial wedge pressure is less than 18 and there's no evidence of late arterial hypertension and heart size is normal. The pleural effusion is absent and absent B Carli lines presence on bronchograms. Here's the alveolar infiltrants tends to involve all the regions of the lung except the prehalar region, which looks like bat wings appearance and have no responding to the diuretics. Okay, now the next question is how to differentiate chest infection from acute respiratory distress syndrome. Here's the signs of infections would be present, such as WBC would be raised and sputum culture and endotracheal aspiration is needed, and here's the fever would be present. Next, what are the Berlin criteria, though it is not so important, but here it is classified into three types such as mild, moderate and severe. In case of mild, here's the ventilation perfusion ratio or the partial pressure of oxygen and fraction of inspired oxygen ratio here in case of mild 200 to 300, and in case of moderate here less than 200, and in case of severe case here's the ratio is less than 100. Now the most important topics here is pathophysiology of the acute respiratory distress syndrome. It is divided into two phases, such an acute phase and a later reparative phase. In acute phase, here's destruction of the capillary endothelium occurs as a result, extravasation of the protein-rich fluid and interstitial edema occurs with release of cytokines and migration of neutrophils. Then the alveolar basement membrane is also damaged and fluid shifts into the aerospace. The stiffening of the lungs occurs and causing the ventilation perfusion ratio mismatch. Okay, in the later reparative phase, which is characterized by fibroproliferation and organization of the lung tissues, if resolution does not occur, disordered collagens and deposition occurs, leading to exchanging lung scarring. The next another short question may be asked that what happens to lung compliance? Lung compliance may be decreased, and what are the long-term sequelae of acute respiratory distress syndrome, or what is in case of long-term sequelae? Here's the mortality rate is around 40% in acute respiratory distress syndrome. So long ICU stay for months, pulmonary infunctions and mild impairment occur, neurocognitive dysfunction and post-traumatic stress syndrome also occurs, and physical developments may be required. Next, the causes of acute respiratory distress, if not coming in the examinations, but it can be known to, it should be known to you that it may be occurs due to infections such as sepsis or diffuse pulmonary infections, such as viral mycoplasma and pneumocystis, pneumonia, and biliary tuberculosis, gastric aspirations, and mechanical trauma such as including head injury and pancreatitis, and other some physical injuries such as pulmonary contusions, near-death fractures with fat embolisms, and ionizing radiations, hypersensitivity reactions like organic solvents and drugs, chemical injuries such as heroin or methadone overdose, acetyl salicylic acids and barbiturate overdose, and paraquats, inhalants also such as oxygen toxicity and smoke, eton gases and chemicals, hemolytic conditions such as disseminated intravascular coagulations and transfusion associated lung injury, and also uremia occurs acute respiratory distress syndromes. Uh, in this all of our enough for this, and the last finally the management of the acute respiratory distress syndromes. It is at first needs ABCD resuscitations and history, physical examination, investigation according to the cause. Admit to ITU, give supportive therapy, and treat the underlying cause. Respiratory support such as oxygen therapy. Here's the positive end expiratory pressure is given. Here's the positive expiratory, higher positive expiratory pressure. It is not high, moderate positive end expiratory pressure is given, because moderate positive expiratory and moderate positive end expiratory pressure, this will prevent lung injury and will improve oxygenations, and patients should be positioned in prone positions, which is around 65 to 70%. Also, prone positions will prevent atelectasis and it do redistribution of the secretions. Low dose steroids are given, which are associated with improved mortality and morbidity outcomes. Identify organisms and treat accordingly. If clinically septic but no organisms are cultured, use empirical broad spectrum antibiotics but avoid nephrotoxic antibiotics. Hemodynamic managements or fluids should be replaced but with no care not to overload. Assessment may be made by measuring blood pressure and urine output. Final assessment may be necessary using a swan gauge catheter to measure the pulmonary capillary waste pressure. If there is evidence of circulatory failure despite acute hydration, such as fall in cardiac or urine output, then consider low-dose dopamine as a renal arterial dilator and dobutamine for its positive inotropic action. If there is fluid overload, consider furosemide 40 to 120 milligram per 24 hours IV. Other supportive cares or nutritional support, such as enteral feeding, is better than parenteral feeding. Venous thromboembolism prevention with low molecular weight heparin, and gastric ulcer prevention is done with prophylactic medications. Next, what are the long-term sequelae I have already discussed is here's some topics are given. Then hot lefts to sends to hematology, biochemistry, and cytology for sputum. Here's the routine investigation is done, such as full blood count, arterial blood gas, blood culture, sputum culture, urine culture, liver function, amylase and lipase and coagulation study. The next question is where you will admit this patient, burn ITO, when to transfer the patients. It is done within 24 to 48 hours of resuscitation the patient. Now, what complications can develop from acute respiratory distress syndrome? I've already discussed that. Complications and problems of can develop while a patient is patient is in the hospital or after discharge. Uh, Blood clots such driven thrombosis, collapsed lungs or pneumothorax, confusions, muscle weakness, scarred lungs, lung fibrosis may occur, or post-traumatic stress disorders such as anxiety and depressions. I think these are all of today. If you have any further questions, feel free to ask me. Okay, thank you, dear doctors.